and we took it to the NMR sensor. They are living, not they are in the case where they are active. And we make the NMR measurement, just dump the result directly to show you. Just one measurement, it's the real-time measurement. So real-time in vitro NMR detection. And this is the first time in the world. You can be sure, just look to my publication in this week's last year. We start from the media. So, and this is the spectra. Then after 2 hours, 12 hours, and so on, until 24 hours. And recently we were able to reach even 72 hours. And after that, the application and the steroid more. And then from that, we were able to detect 23 metabolites, just from one measurement and the time. And then we see, if you look for every metabolites, there's a growing with the time, not necessarily linear. Some of them, they appear at one moment, and this information was never being known. Because the people just come to that last stage here, when it's extraction. And then they make general information about just the last stage. They were not able to study it with the time. Because it was just, they just take the sample, make the extraction, and then analysis, and they say that we have, for example, ethanol. But if you look to the measurement, even we are able to study quantity. So this was the time, 24, just this measurement 24, but we have 72, and the concentration. And this is the cancer steroid, and you see the left time, it's increasing with the time, which is one of the indication, this indicator for the cancer cell. And if we enlarge this area, also we see there's some metabolites increasing, some metabolites is constant. And this information, it's very important for the people who are designing or developing drug delivery, anti-cancer drugs, and other drugs also. So this table, it's the same information. The table just want to show you some important information also. That's lactate was increasing, but look for ethanol. Ethanol is in the back way. Ethanol just disappear after 10 hours. And this information has never been known because the people just reach the extraction, and this just appear at the beginning and disappear after 10 hours. This is one of the most important information. And then there is also another remain is visible after 16 hours, and so on. So this information is very helpful for the people in this field. And one also application, important application, which is this metal complexes as which is anti-cancer drug, which is based on the metal. For example, the platinum, you know platinum, like platinum, cisplatin, oxalatin, and other platinum or tin even these days, it has a platinum inside. And this is used in the cell, it's absorbed, it goes to the RNA and DNA, and it goes to the strand. And after some time, it's either rejected or stay. And the information, this information, how long does it stay inside, where the connection, and what's the mechanism? It's unknown because we are just applying its application. We don't use NMR to know exactly the mechanism and the time. And this is one of the ongoing research in this field. There were also some people using indirect and see to find out the satellite of the PT. But in this research, we were able to directly study the platinum, not rely on the satellite, because satellite is very low concentration and also it has coupling. So this real-time detection of the platinum is we are able to give us information about quantity. Where is the platinum? How much inside the cell? How much inside the DNA? And how much outside? In this case, we are able to study the overdoses because at some saturation point, we don't need to exceed this saturation point, and it has no any more benefit. So I just want to go to the second part of the work now. Second part, it's about imaging. You know this imaging, and in our group we are going to work with micro imaging, which is more important. You know, imaging, it has one disadvantage. It's limited with the resolution because you just can go up to 3 millimeter distance difference. So if you have a tumor, the resolution is 3 millimeter. So if you want to study the spheroid itself and to take imaging inside the spheroid, is it possible with the MRI? It's not possible. So in our technique, we are able to use also to study, microimaging is very important, just it's important due to the human development, this by microimaging and even think, but here it's a conventional MRI, not for the spheroid. For in the microscope and the B1 gradient, we are able to study the spheroid, to make an image of the spheroid. And why? Why we need to study the image of the spheroid? I will come to this point at the end of the talk, but the development to come to this point, it's also done in my group. Just also important information. Look, this is the MRI, you know. This is the magnet, you know. You see from outside it's very beautiful and nice, but actually this is full of helium inside, and it's superconductor magnet. It's up to 7 Tesla. And the problem with this one, it needs helium, and helium is natural resources. This is one point. Helium is very expensive. You can imagine. You can fill this one. The cheaper one is around 40,000 euro per filling. The big size, and could be 20,000 euro, but 40,000 euro per filling, and you have to fill 2 times a year. And there's a risk every time that you have to quench. Then you need the expert, and if it's damaged, internal oil, then you have to replace it. A normal NMR also needs helium, and it can come to even more than 2,000 and 3 times a year. So that means the point, the question, why we don't use permanent magnet, normal magnet, which is, could be big size, small size. The point that we don't use, because this is permanent magnet, because of the homogeneity. This is one thing, very important point. Homogeneity is very bad for the normal magnet, or to say permanent magnet. And the second point also, that it has very weak magnetic field. If you want to reach 7 Tesla, it's very impossible. The maximum one in the world exists almost 3 Tesla, and it's not used for NMR because homogeneity is very poor. And for NMR it's almost 1.5 Tesla. So I decided to develop with my group a magnet for the macro imaging, and we were successful. So I start with the Harbach magnet, Harbach array. Harbach array is very, the principle is very simple, that you have magnetic element, you arrange it in a way, in a sequence, and then you can have very strong magnetic field in one side and very weak in the other side. So if we form in this shape, then we are able to have a magnet for NMR. But still, the homogeneity by this, you have to simulate it and to study it, and that's what we did in our group. The arrangement, there's many equations to follow to find the arrangement, the diameter, the orientation if you have this shape, and so on, and which shape is better. And then I use the simulation for every shape, and we find out that there's the rectangular shape. It gives us the best results. You see, this is, and also the number. This is 2 and 4 and so on. And this is 12 and 14. So there's no improvement after 12, and we decide to start with the 12. And this is the homogeneity of it. It's here, this line, and it's in the NMR accepted. Not perfect till now, but to say it's possible. And you see here the improvement of the homogeneity. After 12 it's almost like 10, and so we decided to take 12 because of the experiment. And this is the magnet I designed myself, calculated with Microsoft simulation, designed with FieldWork, and we transfer the 3D to the graded machine in ESAS to alpha prime. And simulation is 1.35 Tesla. You see the reality at the end. This is the graded machine, this is the design, and here is the plate. So we had to have full plate of that. It took 20 hours, 21 hours of blending. And this is the final product. This is the magnet. It's almost 25 kilogram, and it's also white bore. And this is seldom to find white bore, because the people avoid white bore because of the strength. It goes quadratic. So if you go to the white bore, then you have very low magnetic field. But for imaging, we need high magnetic field. So this is the final product. I have it and it has magnetic field. And the magnetic field is around 1 Tesla. And 1 Tesla, I don't know if you are familiar with Tesla. For this, I have a video, I hope it will work, to show you how big is the 1 Tesla. This is experiment done.
Hello. After our last video, we had some people saying, can you please film a video showing what will happen if the top magnet is allowed to attract the bottom magnet?
So just to show you this measurement done by 2 magnets, 2 permanent magnets, is around even less than 1 Tesla. They are 0.8 Tesla. And he made firstly north to south, north to north, sorry, repulsion, and then south to, and you see the collision, how strong. And this is just 0.8 Tesla, you can imagine.
With nothing in between. We want to see what happens when 300 kilos clamping force meets another magnet when it's travelling at 200 miles an hour. Now, I'm certain the effect will be quite quite spectacular. And before we do this, I'll need to put my safety goggles on.
At this point, you will reflect the polarity to be north to south, and you will see the collagen, because they are now attractive force, and it's almost like 250 kilograms despite a small size.
So, brace yourself.
So now come back to the presentation. So you can imagine what the meaning of 1 Tesla, and you know this is the NMR is working at 21 Tesla. So you can imagine now, but the volume is much smaller. Now at the last slide, I come to this point. This is the spheroid. This is the image of the spheroid done by the micro imaging, and the information you can. The spheroid is just 9,000 cells. It's as a model for real organ, and you see inside that oxygen gradient. You see the distribution of this information just from the imaging. Lactate distribution and concentration also checked by correlation, and so on. It's all the components, all the 23 components can be studied like this way, by just a spheroid. And this is the successful measurement for micro imaging. So at the end, I would like to thank the people who are helping me in this work. The host of the group, Mr. Heather Ruder, and Michel Golashvili, Lambert, they are special in the NMR, and all of the group, of course. And I would like to thank also the people in the Charles University, Professor Shtibankova and Richard. They helped me in the design and simulation of the magnet. They are special in the magnetism. And of course, I would like to thank ISAS, the Institute for Analytical Wissenschaft for Analytical Sciences in Germany. There are 3 branches in Dortmund, 2, and 1 in Berlin. Thank you also for the Deutsche Forschungsgesellschaft for the funding, and TU Dortmund Leibniz Institute for our biceps. It's actually educational and research hospital. They also cooperation with us for the cancer cells, because we are limited with the information in all this type of the bio. It's very big subject and difficult, and they have contributed a lot in this work. And of course, I thank you for your nice attention. Thank you very much.
Many thanks, Dr. Ahmed, for the interesting presentation. Any questions, please, for Dr. Ahmed?
Thank you for the presentation. Yes. Okay. You mentioned much about engineering, physics, mathematics. What I want to ask you from the medical point of view, when you mentioned about the NMR, you mentioned that it has its advantage, that's the limits of detection, so it is not that sensitive in comparison with mass spectrometry. So do you think that can you apply your method at the early stage of cancer, like stage 1, stage 2? Do you think that you can apply it?
Yes, that's a very good question. Thank you. Actually, I just show this part of my work. Now we have another part of my work that we are using this permanent magnet that we are able to study directly. One can put the finger, this is we are going this, put the finger inside this sensor, and we wait 45 seconds up to 60 seconds, and then we have information about the blood component, especially the lactate, because lactate is an indicator for the cancer or for the stress. So we are developing this with kind of like software cooperation with the group. I don't know the name of the software, that we have the correlation. It's based in the Bayes and based NMR. Then we can have the information about the cancer state of this human or this patient. Yeah.
Very nice. We are aware that in particular molecular MRI has the limit that is not, of course we have to create new contrast agent that can amplify, that can reduce so the can improve the quality of the images. But do you not think that a step ahead can be obtained by combining several technique information, some immunoassay or some detection combined also with it? So I mean, perhaps the goal is to combine more data and it's like a mosaic that come from NMR data and some specific detection that can be, because the sensitivity of immunoassay are at a very, very low concentration. Perhaps the combination is more effective to have a wider information. Only one, so you mean, you said lactate, but one molecule is not enough. So we have to combine the pattern.
I mentioned the lactate as example. No? We have actually able to analyze 150 different metabolites. And actually to the first question, it's very important also that there is actually available now, they are working, not in my group, but I know that they are working with the NMR with mass spec together, combined together in one device. And in my group, we are also trying to combine IR, FTIR on IR, Raman with the NMR. So there's also now a research in this direction. And I know one group with Professor Bayari from USA, we will have maybe, I hope, cooperation because he's able to study single cell analysis by IR, and we try to combine together with our group.
Thanks, Dr. Ahmed, for this amazing presentation, which grasped really our attention. I'm wondering if you use normal pulse for your cancer cells or magic angle pulse, because I can't differentiate if you treat it as liquid sample or cell sample. Could you verify this?
Yes. Actually, we are using liquid state NMR without magic angle spinning. We have another machine for magic angle spinning for tissue, because it's a gel, or need to say between liquid and solid state NMR. This is liquid state NMR, and also we have now a research to improve like dipole-dipole, to remove the dipole-dipole interaction by using another called selective pulse excitation. We are in this work. We have some, basic results, but it's promising. So in this research, we are using, not mass, only for tissue, it's normal pulse, and it's sufficient for liquid state NMR. What kind of pulses? We are using more, not just this called FID pulses or Bloch pulse. We are using more complicated like TOXI and COSI and DOSI. There are several pulses because here we have to clean the signal. The excitation condition is not perfect as conventional MR, so we have to use, and we use special pulses which called selective pulse excitation developed by the 2D COSI pulse.
Thank you, Dr. Ahmed, for your presentation. You said you can use the NMR for measuring the drug concentration outside the cell, inside the cell, and drug attached to DNA. So do you think this technique should be used in the future to measure the exact dose of anti-cancer drugs? And second question, do you think different ethnic groups with different genome or differences in the genome should be given different dose of anti-cancer drugs?
Let's go to the first question. That we can measure what's the platinum or the anti-cancer core inside, outside, and also in the plasma. The reason because of the different of the relaxation correlation, and this is the reason. Then they have different frequency and different chemical shift. And we have to use also relaxometry, called NMR relaxometry. I just not mention it, but just mention the information. Of course, it can be used in the future. It's still at the beginning. I have put in this work 3 patents and 2 in the other work. And these 3 patents, they are now in the commercialization. So there are some in company like Magnetic, they are interested in this, and they are communicating with us for that. The second question, I did not get actually the point. What? Different
ethnic groups with different genome differences.
Okay. At the moment, we are just receiving the sample from the patient from Stuttgart. They ask cooperation also with Stuttgart. They make the sample ready for us because we are not taking care of everything. We are more like biomedical sciences. So this huge effort, we are taking it ready from Stuttgart and from IFADO. And at the moment, we are using it from the female breast cancer and colon breast cancer from the patient from, I mean, it's also available, which is called T9 colon cell line. I don't know exactly if it's different genome, but maybe in the future. I have no enough idea about the future about this work.
You showed that the spheroid have different sort of metabolism, whether they're external or internal. Does your methodology differentiate whether the lactate is produced from the inside cells or the outside cells?
You mean that all these metabolites are produced inside cells and diffuse outside?
No, isn't it within the spheroid is the internal cells that are different than the ones from the sphere?
Exactly. I show from the image that they are different in concentration every layer even. The spheroid is almost like between 200 to 500, and in spite of this small, very small volume 3D, there's also a distribution inside. And this is the most interesting information.
Most of your measurements are done not on cell extract, on whole cells?
Yes, yes, in living cells, in real-time living cells.
And do you have any sort of standards to make sure that these are the right metabolites? So do you use purified glucose or purified lactate to make sure that these peaks are the correct ones?
Yes, yes, we have actually several measurements for control first. We don't start just by, then we have several measurements for control and for comparison before we start. And we start with the standard media, and then we have the free cell, the media alone for 72 hours, and then after that we have the control measurement and then the real measurement. If there is no question, I also would like to thank Dr. Ghassan Abu Sheikha for, he invited me with Dr. Marwan last year, and we have started discussion for collaboration. And I have actually 3 projects collaboration with Jordan, German University, Yarmouk University, and also Just. And he invited me and we had a nice discussion. And last month we were successful to submit a proposal for the work, and hopefully in 15th of November we will have the result evaluation, and hope we have started collaboration. And I got actually like 13 students last year from Jordan in my group, and 4 staff for this work. Thank you very much.
Many thanks again, Dr. Ahmed.
Okay, next presentation for Professor Nasser Al-Sharif. I think now all of us are familiar with Dr. Nasser. We listened yesterday to his nice presentation, but just to remind you, it's a long CV actually, but I'll try to summarize.
You don't have to.
We listened to it yesterday, but I repeat the headings. Okay, Dr. Sharif received his PhD from Creighton University Medical Center in toxicology in 1992, his master's degree and pharm degree in pharmaceutical sciences from University of Nebraska Medical Center, 1988-1987 respectively. Dr. Sharif is currently a full professor of pharmacy sciences. He served as the Associate Director of the Web-Based Pharmacy Pathway 2001 to 2006. Dr. Al-Sharif is a winner of the Innovation in Teaching Award Competition 2000 and 2006. Professor Al-Sharif, his presentation today is entitled Pharmacist, key member of the ambulatory care team to optimize patient care. Please, Dr. Al-Sharif.
Thank you very much. Assalamu alaikum. Thank you very much all for coming. Thank you, Dr. Hassan and the organizing committee. It's been a wonderful experience so far. This is my first time at the university in terms of this conference, so it's been a wonderful experience. Kind of sticking with the theme for the conference, which is a global perspective. We talk about pharmaceutical sciences, but also pharmacy practice. So I'm going to switch gear. We're going to talk about pharmacy practice. Yesterday we talked about what is needed in general in terms of pharmaceutical sciences, and pharmacy practice in general. Today, I'm going to concentrate on, I think, a very important one from a global perspective, which is the role of the pharmacist in ambulatory care. When you think in terms of the Arab world, and certainly here in Jordan, it seems like between one pharmacy and the next, there is another pharmacy, right? And I'm not sure about the military services in terms of how many clinics and so on, but certainly pharmacists can play a major role in terms of ambulatory care. So that's where we're heading. I'm not going to have any structures, no equations and so on, just sit, relax, and hopefully we'll have a good interaction related to this. So a key thing really from a general perspective in terms of where pharmacists practice in ambulatory care might be different. So I'm going to show you, at least in the United States, where they practice, but I want you to think in terms of Jordan, in terms of maybe the military service or other services, and where pharmacists can be embedded to really do this kind of work. We also need to identify the rationale. Why should pharmacists be part of ambulatory care? So we'll talk about the rationale. Discuss the barriers for including pharmacists as part of the ambulatory care team. And I think the barriers might be different depending on where you live in the world. And provide examples. Some of these examples should be general, really, across the globe in terms of what pharmacists. But again, there might be unique things here in Jordan, so think about those as we discuss these. What do we need to have a successful kind of practice for the pharmacists in ambulatory care? We'll talk about that. And again, discuss the evidence for the value. Why should we do it? What is the value? And go with that. But again, I think the key thing in terms of, again, the global perspective, whatever is happening somewhere else in the world, whether it's in the United States, Europe, India, Pakistan, and so on, what are the implications here at the university, but also in general in terms of Jordan? So these are some settings in the United States, and a lot of settings in terms of where pharmacists can practice. Certainly ambulatory care settings, specialty care, managed care, community pharmacy, outpatient hospital, home care, and even in assisted living, where the patients somewhat, are able to function, do things, but pharmacists now are being embedded in assisted living. But even in nursing home, where patients stay for a long time, they have chronic diseases and so on, and pharmacists are there. So again, think where in Jordan pharmacists can be embedded. What is the rationale? Our students are so qualified in terms of their education. And in terms of using that education to help healthcare in general and patients in general, it is a professional responsibility. It's part of pharmaceutical care. It's part of medication therapy management, whatever you call it in terms of the practice that exists here in Jordan. But it is a professional responsibility. You're vowing to provide a service to the community. One of the presenters yesterday talked about pharmacists in Palestine and their lack of kind of ability to even just counsel about inhalers, not to target these pharmacists. But I think that is a simple kind of thing in terms of patients with asthma, bronchitis, COPD, and again, pharmacists should take that responsibility to educate the public and so on. So it is a professional responsibility. It meets societal health issues. Again, that's part of what we're trained to do. And if we don't do it, then we're really lacking in terms of that professional responsibility and willingness to really do what we're about to do in the community. Better patient outcomes. Studies after studies have shown when pharmacists are engaged in the healthcare of the patient, then you're going to get better patient outcomes. Decreased hospital stay is a major thing now in the United States. That goes hand in hand with decreasing costs and so on. And pharmacists have been shown to really make an impact in terms of how long patients stay in the hospital, and that's really critical. Continuity of care, I don't know how many of you talked about medication reconciliation, but this is really critical. Every time a patient is transitioned from, even in the hospital, from one ward to the next, that's a transition in care, and a lot of errors can happen if there is no medication reconciliation. And that's not even thinking about going from the hospital to the community. Major issues can happen there. So that's becoming very big in terms of pharmacists and their contribution in the United States. Another key issue, and I think it was mentioned yesterday, about how long patients can stay outside the hospital before they come back in the hospital. In the United States, insurance companies now will not pay if the patient goes back to the hospital after being discharged after 30 days, or before 30 days, I should say. They're not going to get paid. This is hospitals. But again, it goes back to the profession, and whether it's here in Jordan or anywhere, it's about taking charge back of our profession. Right, Dr. Willie? Yes. We want to take back charge of our profession, our image, who we are, okay? We want to enhance pharmacy services, what we do, and we want the public to acknowledge that we do a good job, and a job that is critical, important for the public. We want to improve pharmacists' image as a provider. We're not just dispensers, or we don't have cognitive abilities to really impact patient care. We really can make a big difference, and we want that image to be as such. And certainly looking at job opportunities for pharmacists. We have so many pharmacy schools in this region. Even in the United States, we started with 81, 10, 15 years ago. We have about 132 pharmacy schools. We need jobs for these students. And it's not fair, you know, if there is no new job opportunities. And I think the role in terms of ambulatory care is so critical, and it can create many, many job opportunities for pharmacists. So there are barriers, no doubt about it, for any kind of change or whatever paradigm you're thinking about in terms of what exists, what you're trying to change. There are barriers. Certainly education is a major aspect. Certainly shifting to a Pharm D program does not really mean that what is going to happen outside is going to really accommodate that shift. You know, still many of our students are disillusioned in terms of what they're being taught, and then when they go out and practice. So how does the curriculum help in general? But also, how can we continue with training, whether it's a Pharm D program, a master's program, PhD, residencies, fellowship, to really fine-tune the skills and the abilities of our students to do kind of function in the ambulatory care setting. Lack of collaboration and support from physicians and hospitals and clinics. Again, the role of the pharmacist is not recognized by many. So how can we make sure physicians agree to have collaborative agreements with pharmacists, and they respect the knowledge that the pharmacists have, and they feel it's an asset for them in the clinic, in the outpatient pharmacy, or whatever they practice. Again, in terms of legalities, in terms of the Ministry of Health, Ministry of Labor, and so on, and the scope of practice of pharmacists. I think in this part of the world, it's great, because pharmacists are always being asked to somewhat diagnose, and sometimes they can prescribe, right? You know, maybe it's changing, but for many years, that's been the case, and pharmacists can, you know, somewhat diagnose and prescribe. So again, the scope of the practice is great, but if it can be solidified in terms of the regulations and what pharmacists can do, and so on, and how they can contribute, that would be fantastic, because there is already some things happening, even though it's maybe not from a legal perspective or defining a scope of practice that is clear, but it is happening. And then how can we reimburse the pharmacists for those kind of functions that are more cognitive, rather than, again, the logistical aspects of running a pharmacy and dispensing and so on, and to really make sure that they get reimbursed for these kind of activities. In the United States, certainly we have technicians, and those technicians play a major role in terms of freeing the time of the pharmacist to do the work that needs to be done from a clinical perspective. So, you know, how do we train our technicians and so on is really critical. How do we change the misconception of the public about what pharmacy is all about, and seeking pharmacists for all that kind of services that they can provide is another critical thing. Lack of availability of automation. Automation can really help. Certainly there is issues with bringing in computers and informatics and so on, but it provides really, you know, talking about research with looking at the blood with Dr. Amanda. I mean, I would love to see people going out and collecting blood from all over the world and really start analyzing what are we looking at in different regions and so on. But as human beings, we cannot do that, but computers can do that and provide us with fantastic data to help us really optimize care on a regional basis, country basis, and so on. So automation is really critical, and data analysis and analyzing the population you're dealing with as a pharmacist, as a healthcare provider is so critical, it's so critical. Lack of established standards for best practices. Again, we cannot send our graduates out there without giving them some guidelines for best practices. Medical doctors do that, nursing do that, so we need to make sure we identify for our practitioners and for our students when they go out, what are best practices and how they can fit in the big picture of the healthcare team. And certainly when they go out, they feel comfortable that they can produce something of value for their patients. And again, lack of practice setting. We're lucky in the United States in terms of exploring many different ways where pharmacists can be embedded. Again, how can it be done here in Jordan to optimize the value of the pharmacists in these settings and create more settings? I think that's the key thing. So what are some of the services? I think you should be kind of familiar with some of these things. Pharmacists now are doing diabetes education, asthma education, hypertension, clinics, all kind of things, community clinics, you name it. Pharmacists are contributing, and many studies have shown, again, their value in these kind of services. Health screening, more and more health screening, whether it's hypertension, diabetes, hyperlipidemia, all aspects of screening, pharmacists are being involved. Health promotion. Most pharmacy schools now in the United States are including public health as a required course, because it is about the epidemiology of the population you're dealing with. It's about prevention, it's about education, it's about counseling the patient and so on. So now we have a required course in public health, and it's all about promoting and prevention. Okay? Immunization. Most pharmacy schools now, their students after the first year are certified immunizers. So they can go out, whether they're working as pharmacy interns and so on, and do immunization. And the pie in terms of the number of pharmacists that are involved in immunization in the United States is getting more and more bigger in terms of pharmacists doing a lot of the immunization. Okay? And certainly smoking cessation and other kind of prevention and promotion. Other things, specialty compounding, dietary supplements, kind of counseling and over-the-counter. But overall, drug information and patient education and counseling. Most pharmacies now will have a counseling room, and pharmacists would sit down and talk to their patients about their medication, their overall health, and how it interacts with drugs and so on. So that's really important. The general kind of picture in terms of what pharmacists do is this whole thing about medication therapy management. And the key thing is, if you're going to do it, it has to be based on what medication therapy management. So you have to coordinate this with the physician. You cannot do it on your own. So you're working collaboratively with the physician to really make sure, you kind of know about your patient, what they do, and so on. You have to establish a treatment plan. You have to educate the patient. You have to follow and monitor that patient. You have to modify the treatment in coordination with the physician and measure and document patient outcomes. If you do all of this and you don't document it, nobody knows about it. So you really need to make sure you document it. So again, whether it's the Ministry of Health or others, or even publishing some of the work you're doing, nobody knows about what you're doing. So you have to do it. But really, another key thing is, we should be able also to discontinue or recommend discontinuation of treatment. So it's not about all of that. No, it's about talking to the physician and saying, you know what, we think this patient does not need this medication anymore. So discontinuing treatment should be also on our radar in terms of what we should be doing and so on. So what do we need to do this? You do need a referral system or a collaborative agreement with physicians and so on, so that you're able to follow patients and do your medication therapy management. Again, you need to document. Okay, and document your meetings with the patient, even phone calls with the patient, what you did, what you suggested, and the treatment plan and all that stuff need to be documented, and communication across the board with other healthcare professionals that are taking care of that patient, documenting in charts, in your system, computer system, and so on. And again, what we need is to expand the scope of the pharmacists. In some states now, they're looking at the pharmacist as provider. In collaborative agreements, pharmacists end up getting a code to charge the patients for the services they're doing. That code would have been for the physician. Now it is the pharmacists that charge for these services because they're the ones who are doing that service. All right. So that's really another critical thing. This one is my cup of tea, or whatever you explain it, in terms of culture competency. How many of you heard the term? You did? Oh, of course, Dr. Abir. Yeah, sure. Well, cultural competency, if you think in terms of practicing in an ambulatory care setting, who are you seeing? if you're in Jordan, I was just in Abu Dhabi and in Qatar. I think I saw the whole United Nation in that two countries. There is every ethnic, religious group, well, I don't know about religious, you cannot know, from at least ethnicity and racial, okay? In the United States, we have every ethnicity, religious group, you name it, we can't say that, right? Okay? But I mean, if you cannot optimize the patient care based on their culture, whatever that culture is in terms of their beliefs, their values, their religious beliefs, and so on, you're gonna really do a negative thing in terms of dealing with that patient somehow, someway. If you have a provider bias towards African Americans or people of color, or if you have a gender, you know, female, male issue, if you, in this part of the world, sadly, whether it's, you know, national origin, whether it's Pakistani, Indian, the same thing in the Gulf, there's many issues in terms of how we deal with patients in general, even within the same country, people from the north, the south, and how they're being kind of treated. So our biases make a big difference in terms of how we optimize patient care. And there are many studies that have been done with cardiologists in the United States looking at how they deal with Caucasians compared to African Americans, and the kind of services that are provided completely different based on, sadly, the color of the skin. So it's gonna hunt you one way or another in terms of how you provide services. And if it's not on your radar, ultimately you're gonna negatively affect the patient care. We did a study about provider bias, and with talking about the military, one of our students was a graduate working in one of the biggest Air Force bases in the United States. And we did the survey, and after we did the survey, she goes, you know, Nasser, I've never recognized this, but we discriminate based on the rank. If the brigadier general comes in for his prescription compared to one soldier, most probably they're going to treat him much more, ooh, you know, watch out kind of thing. And she said, you know, now I'm sensitized that I need to treat all my patients the same way. All right? With all due respect to you, sir. You deserve all the respect. But the other aspect of that is not only cultural competency, it's, what's that?
As a good example.
Yeah, nothing against you. The other thing that goes hand in hand with that is cultural humility. And cultural humility for me is to practice in an egoless kind of way. You don't have any ego. And that means you identify the fact that you can make mistakes. You identify the facts that, you know what, I don't know this. I need to check with a physical therapist, occupational therapist, or another pharmacist. So they go hand in hand. So again, I don't care which practice setting, but certainly in the ambulatory care setting, you're going to see a wide range of people. And if you don't have that kind of cultural competency in you to really want to learn about your patient, their culture, their beliefs, their values, and so on, you're not going to optimize the care of that patient. And if you come in with that ego that I know everything and all that stuff, good luck. You're going to really harm somebody in the process. All right? So those are really two key things. I do teach a course in cultural competency for healthcare professionals. And again, whether it's medication therapy management or whatever, if the students don't exhibit these kind of skills and attitudes in terms of cultural competency, humility, it's not going to happen. And it is in pharmacy. Nursing and medical schools have talked about this for a while. Thank God now we're getting more and more in terms of recognizing this is critical for our students, and hopefully it is critical across the globe. And I think it's really important. So what is the evidence for the importance of ambulatory care pharmacists and their role? Certainly decreasing hospitalization, drug cost savings, improved quality of care. That's not me talking. There are many studies, and I don't have time to really go through some of these studies, but all of these have been shown. They improve outcomes for the patient, public health benefits, meet the